Well, good afternoon, everyone, and thanks so much for joining us today. This is our second webinar that we're featuring this week during STI Awareness Week, sponsored by the New York City Prevention Training Center. Tomorrow, we have another webinar that will be focused on syphilis cases, and I will put that link in the chat if anyone has not yet registered and is interested in joining us tomorrow. Today's webinar is focused on congenital syphilis, and our presenter is Dr. Jason Zucker. Dr. Zucker is an assistant professor of medicine at the Columbia University Irving Medical Center and the assistant medical director of the New York City STD Prevention Training Center. Trained in adult and pediatric infectious diseases, he has extensive experience providing sexual health to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. Thanks so much, Dr. Zucker, for your presentation today.
Thank you, Gary. And good afternoon, everybody. And thank you all for coming to join to talk to us about this important topic. I'm really thrilled to be here today. As Gary described, I'm an adult and pediatric infectious disease physician, and I have an interest in sexual health, which means I get to do a lot of consults and get calls about mothers, fathers, and their children, sometimes even in the same consult. This is really important because, as you'll soon see, regardless of your role on the medical team, determining how to manage congenital syphilis requires understanding of the mother's diagnosis or the pregnant person's diagnosis, as well as how to treat the newborn baby. I have no disclosures. So the goals for today are to understand syphilis history, microbiology, and the recent epidemiology, to know the screening and treatment recommendations for syphilis in pregnancy, and know the screening and treatment recommendations for babies born to pregnant persons with syphilis. I suspect everyone's here today because congenital syphilis has been in the news a lot. We've been seeing soaring rates of congenital syphilis in counties across the country. The CDC released the 2022 State of the STDs very recently. And for the 7th year in a row, STIs are increasing. This includes an 11% increase in gonorrhea since 2018, an 80% increase in cases of syphilis since 2018, and a staggering 183% increase in congenital syphilis since 2018. And that's really why I'm here today. But it's not just this 183% increase. The numbers are actually worse than that. When you look going back not just 5 years, but 10 years, it's been a 100-fold increase, or a 10-time increase, or a 100-fold increase since then, from just 335 cases in 2012 to over 3,700 cases in 2022. And always before I dive in, I think it's really important to highlight that it did not have to be this way. In fact, in 1999, there was a national goal to reduce primary and secondary syphilis to 1,000 cases or fewer nationwide, and increase the number of syphilis-free counties to 90% by 2005. Hopefully, as you saw, we have more than 1,000 congenital syphilis cases and are nowhere near elimination. However, the words they said back in 1999 hold true today. As we approach the end of the 20th century, the United States is faced with a unique opportunity to eliminate syphilis within its borders. Syphilis is easy to detect and cure, given adequate access to and utilization of care. Nationally, it's at its lowest rate ever recorded, confined to a limited number of geographic areas. The last epidemic peaked in 1990 with the highest syphilis rate in 40 years. Eliminating syphilis would have far-reaching public health implications because it would remove two devastating consequences of the disease: increased likelihood of HIV transmission and compromised ability to have healthy babies due to spontaneous abortions, stillbirths, and multi-system disorders caused by congenital syphilis. This chart shows reported cases of syphilis by stage of infection from 1941 through 2019. And I placed a blue arrow over that peak from 1990 and a green arrow over our current day. And as you can see, we're closer to that peak of 1990 than we are to elimination. And the second chart shows the same data, but just over the last 10 years. So you can better see the dramatic rise in cases of total syphilis during the most recent period of time. We know that syphilis cases are not distributed equally. Rates are higher among individuals by their gender, age, and ethnicity. In the chart on the left, you can see rates of syphilis by age and sex at birth. And as you can see in both men and women, rates are highest amongst those who are younger, with a peak in females during their childbearing years. You can also see that the rate amongst men is several times higher than that among women, but that really hides the changes that are occurring. What you can actually see is that while cases are highest among men who have sex with men, the rate amongst men who have sex with men has plateaued over time. And while it's still continuing to increase, it's actually increasing faster among women. And so you can see women went from here to be the second most common group. Additionally, this chart on the right shows the rates of reported syphilis cases by sex and the male to female ratio. As you can see from the bright pink line, the male to female ratio in the United States is declining because although infection rates are increasing in both groups, the infection rate in persons born female is increasing faster than that of persons born male. Mirroring this trend in overall syphilis incidence, you can see that rates of primary and secondary syphilis among women of childbearing age, as well as congenital syphilis, have been increasing, with higher numbers reported across all regions of the United States. However, this is something we can prevent. Timely syphilis testing and treatment during pregnancy can prevent as much as 90% of cases. Newborn syphilis happens when syphilis is not identified and treated properly during pregnancy. In this recent review, 40% of cases occurred due to inadequate treatment, 37% due to no timely test, and 11% due to no treatment. For 12%, there are other reasons or missing data, but we know that there's a large proportion of cases that we can do something about. Why do we care? Well, there are lots of reasons, but in this case, it's the fact that syphilis can infect the placenta and through transplacental infection affect the baby. Transplacental transmission to the fetus occurs approximately the 9th to 10th weeks of gestation, although it can occur at any stage of disease. Fetal abnormalities result from a robust inflammatory response. Therefore, they're most pronounced after 20 weeks of gestation, since the fetal immunologic response is poorly developed in the first half of pregnancy. Congenital syphilis can have devastating outcomes. Congenital infection can result in miscarriage, stillbirth, preterm birth, impaired fetal growth, neonatal mortality, and many other adverse outcomes. In fact, it's recommended that any woman who delivers a stillborn infant after 20 weeks be tested for syphilis. And the risk of infection to the neonate is related to a few factors. The first is the stage of syphilis, with earlier stages being higher risk than later. Maternal infection late in pregnancy being higher risk than earlier in pregnancy. And finally, what I'll highlight a lot today, failure to adequately test and appropriately treat maternal infection leads to increased risk of congenital infection. The diagnosis of congenital syphilis can be difficult. Maternal non-treponemal and treponemal antibodies can be transferred through the placenta to the fetus, complicating the interpretation of serologic testing. Evaluating and treatment decisions are really based on 4 steps. The first is identification of syphilis in the mother. The second is to determine if the pregnant person's treatment was adequate. The third is to look for the presence of clinical, lab, or radiographic evidence of syphilis in the neonate. And the fourth is to compare the pregnant person and neonatal non-treponemal serologic titers. Now that you know what we need to do, I'm going to introduce you to 3 patients. They're all based on real patients. However, details have been changed to protect patient privacy. The first patient is Jen. Jen's a 34-year-old bisexual female, pregnant with her first child. Her partner of 10 years is a 36-year-old bisexual man, and they're in a committed open relationship where they both have same-sex partners. She presents for prenatal care at about 10 weeks gestation. Next is Eve. Eve's a 29-year-old female pregnant with her first child. She described her baby's father to me as a fling and that he does not intend to be involved in the baby's life. She presented for prenatal care at about 12 weeks gestation. Finally, meet Alex. Alex is a 24-year-old female pregnant with her first child. She's pregnant with her high school sweetheart, and neither of them has had any other sexual partners. So the first question is, who should be screened for syphilis? And hopefully from the concept of today's talk, everybody gets the idea that it should be everybody. Like all infectious disease outbreaks, if we want to reverse the increasing number of cases, we need to test and treat more people. These are the current CDC recommendations for syphilis screening. And for pregnant women, the last row, it's recommended to screen during the first prenatal encounter, plus the third trimester and at delivery if high risk or in an endemic area. I'll add that many jurisdictions are now requiring third trimester and delivery screening due to the high rates of congenital syphilis we're seeing. And I do think it's a good idea to screen latent pregnancy, as people who can seroconvert latent pregnancy is a common reason for misdiagnosis. One other thing I'll just note and highlight today is that not all females are infected with syphilis during the course of pregnancy. So it really is good to think about screening for syphilis anytime you're thinking about screening for sexually transmitted infections. So as a reminder, we should be doing complete STI testing on all of our pregnant patients. While that was done here, I cut the additional tests out for time, but please assume they received comprehensive sexual health care, complete testing, and any additional tests were negative. In our case, our first patient, Jen, had a reactive RPR with a titer of 1 to 1. Our second patient, Eve, had a reactive RPR with a titer of 1 to 8. And our third patient, Alex, had a reactive RPR with a titer of 1 to 1. So with our tests back, what do we need to know to properly evaluate our pregnant persons and their future children? As I said before, the first step is to identify syphilis in the pregnant person. And for that, we need testing. The tests used for diagnosing syphilis are the same in both pregnant and non-pregnant persons. There are two types of tests for syphilis: non-treponemic quantitative tests and treponemic qualitative tests. I can spend an hour or longer talking just about syphilis testing, but in the interest of time, as that's not the focus of today, I'll just briefly remind you that there are two different algorithms. One other thing to remember is that testing for syphilis is primarily relevant for persons who don't have clinical signs and symptoms of syphilis. However, we want to reverse the growing trends in syphilis. We do need to screen and screen often, and there are these two screening algorithms available. The traditional algorithm starts with a non-treponemal test, almost always the RPR, and if positive, uses a direct treponemal test for confirmatory testing. As a reminder, a positive confirmatory test shows evidence of syphilis infection, but this could be evidence of a current infection or a prior treated infection. And interpreting the quantitative non-treponemal titers are critical for making that distinction. And we'll talk specifically about that in a couple more slides. The second algorithm is the reverse algorithm, which starts with a direct treponemal test, either an EIA or enzyme immunoassay, or CIA chemoluminescence assay. If positive, it reflexes to a quantitative non-treponemal test. And if those results differ, then you perform a second direct treponemal test to break the tie. Again, while I didn't go through the entire algorithms today, I am happy to take questions about them in the end if there's any questions. But what's important, if you use these algorithms, you're able to interpret syphilis testing. In terms of other workup, in addition to serologic testing, there can be other signs of congenital syphilis. Fetal infection may be suspected if there are characteristic nonspecific findings on ultrasound after 20 weeks gestation. Hepatomegaly and placentomegaly are early findings, while anemia, ascites, and hydrops occur later in the course of infection. It's important to note that an abdominal ultrasound is not diagnostic of fetal infection, and a normal ultrasound does not exclude fetal infection. Now, returning to Alex, who you may remember as having a baby with her high school partner, neither of them has had any other partners, so they're convinced this had to be a false positive test. And they're right. Her RPR was positive, but her confirmatory treponemal testing was negative, making this likely a false positive result. False positives are more common in pregnancy. A positive low titer non-treponemal screening test can be considered a transient false positive result if the confirmatory test is negative, the patient is asymptomatic, and they're at low risk for infection. Repeating the RPR right now is likely not beneficial, as these can remain positive for up to 6 months. They do recommend that all persons with a false positive pregnancy should follow up after delivery. However, for Alex, this means that her baby does not need further workup. This is a surprisingly common question, but since Alex did not have syphilis, her baby does not need any further workup, and this is the end of her workup for syphilis. So in Alex's case, we did not identify syphilis in the mother. However, what if mom had syphilis? Well, in that case, the next thing you need to know is whether maternal treatment was adequate. So how do we determine if treatment was adequate? Well, we need to know about the symptoms at the time of diagnosis and history of prior testing for proper staging. We need to know the number and timing of any treatment given to confirm appropriate treatment. And finally, we need to think about the chances of reinfection, including whether the person's partner was treated. So let's go back to our patient Eve. Her labs were notable for a positive RPR with a titer of 1 to 8 at the end of her first trimester, and confirmatory testing returned positive. We took a detailed history and found that she had never had any symptoms, but also had never been tested for syphilis before. So what stage is she and what treatment does she need? Before we get to treatment, understanding adequate treatment requires us to understand the proper staging of syphilis. This diagram is from the New York City STI Prevention Training Center and New York City Department of Health syphilis monograph, and I think highlights the stages of syphilis really well. It starts with an incubation period. After a recent exposure, you actually may not test positive or have symptoms for up to 90 days. This is important because it means pregnant persons exposed to syphilis may just need empiric treatment as opposed to waiting for the RPR to turn positive. After incubation is primary syphilis. Primary syphilis is defined by local symptoms. Traditionally, the painless chancre we think of typical for syphilis that occurs at the site of inoculation. So primary syphilis again is local. Lesions present at the site of inoculation. It's important to remember these are usually painless ulcers, which means if they're not in a visible spot like the rectum, vagina, or oral cavity, it's easy for them to go unnoticed. And so patients may test positive without ever having seen a lesion. They're often associated with regional or bilateral lymphadenopathy, which may be an additional clue. This also highlights the importance of doing a complete physical exam in order to better stage syphilis, as it will have an impact on how much treatment we provide patients. Primary syphilis is highly infectious and generally resolves in 1 to 6 weeks after infection. One thing I do want to highlight is that while the classic presentation is that of a single painless ulcer or chancre at the site of infection, we are seeing more and more atypical presentations. These include multiple, atypical, or painful lesions at the site of infection, once again reminding us that syphilis is the great imitator, and we need to have a high suspicion for syphilis almost at all times. After primary syphilis is secondary syphilis. This is disseminated symptoms. This is what we traditionally think of as the rash on the palms and soles, but also includes other disseminated symptoms like generalized rashes, generalized adenopathy, fevers, chills, fatigue, hepatitis, and other symptoms. It generally occurs 4 to 8 weeks after infection, resolves in 6 weeks, and is highly infectious. This is a table from the monograph I mentioned earlier that outlines some of the many potential manifestations of secondary syphilis. Finally, latent syphilis, which we talked about a little earlier. Latent syphilis is by definition asymptomatic. Early latent is when it's possible to document non-reactive syphilis serology within the past year, or a patient with a history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or syphilis of unknown duration. These designations are important because they determine what is adequate treatment for syphilis. Just as one more reminder, latent syphilis requires no exam findings of primary, secondary, or tertiary syphilis. This is commonly confused, but for patients with clinical signs of primary or secondary syphilis, they do not need treatment for late latent syphilis, regardless of the date of their last syphilis test. And all of what we discussed so far plays into treatment for syphilis, which is determined by stage. Here we have the CDC recommended treatment and alternative treatment options. For incubation, primary, secondary, and early latent syphilis, it's a single dose of benzazine penicillin G, or alternatively 14 days of daily doxycycline, twice daily doxycycline. For late latent syphilis of unknown duration, or tertiary non-neurosyphilis, it's benzazine penicillin G weekly for 3 weeks, or doxycycline twice daily for 28 days. And for neurosyphilis, ocular or otic syphilis, it's IV penicillin for 10 to 14 days or IM penicillin for 10 to 14 days. However, in pregnancy, that treatment is the same, but we don't use alternative regimens in pregnancy. Particularly, we don't use doxycycline. Pregnant women who have a history of penicillin allergy should be desensitized and treated with penicillin. One thing about treating syphilis in pregnancy that may be different, the CDC actually recommends considering additional therapy for women who have primary, secondary, and early latent syphilis with a second dose of Pen-G 1 week after the initial dose. This is based on PK/PD data suggesting altered penicillin levels in pregnant women with limited efficacy data and no randomized control trials, but I generally recommend it be done, particularly later in pregnancy. Another very common question is about missed doses. In general, clinical experience suggests that 10 to 14 days between doses for latent syphilis might be acceptable before we're starting, even though an interval of 7 to 9 days is preferred. This is not the same for pregnant women, where missed doses greater than 9 days are not acceptable for pregnant women receiving therapy for late latent syphilis, and pregnant women who are more than 9 days from their last dose should repeat the full course of therapy. I see a question about the bicillin shortage and is it ending anytime soon? And the answer to that is probably not. So the FDA is continuing to report a shortage of benzazine penicillin from the manufacturer with what was previously an estimated recovery time of early 2024, now late 2024. What's really interesting about this is unlike prior shortages, this one is being driven by increased demand. And that's likely because we're having increased cases of syphilis, but additionally, we're seeing increased usage of this drug for other things like group A strep. However, this means that because it's a demand issue and not a production shutdown, it is possible to get supplies, although sparingly, and that affects how we manage this shortage. However, before I talk about how to manage the shortage, one more thing you should be aware of is that I mentioned earlier, in some cases, intramuscular procaine penicillin could be a potential alternative. However, this was discontinued by the manufacturer, and so will not be a potential option moving forward. And this puts us in an uncomfortable position for treating syphilis in terms of our recommended option. But for pregnant persons, we don't have additional options. And so we really need to make sure that we are monitoring our supply and forecasting needs of benzazine penicillin, appropriately staging syphilis so we don't overtreat and use additional penicillin, and prioritizing our use of benzazine penicillin, particularly for pregnant persons and their children. In the case of congenital syphilis, we don't have other options, and so we need to prioritize benzazine penicillin for those groups. So how do we determine if the pregnant person's treatment was adequate? Well, as we discussed earlier, we have to stage the disease using symptoms at the time of diagnosis and a history of prior testing. We need to confirm any prior treatment based on staging and the number and timing of any doses given. And we need to assess whether or not partners were treated and if there was a chance of reinfection after the most recent treatment. So based on what we just reviewed, Eve was diagnosed with latent syphilis of unknown duration, and she received benzazine penicillin G intramuscularly weekly for 3 weeks and took all of her doses within 7 days. However, one additional thing you may need to understand to properly stage syphilis is how to interpret RPR titers. In the case of Jen, her RPR returned reactive with a titer of 1 to 1 and a positive confirmatory test. However, when you obtained her prior records, it turns out that Jen actually had early latent syphilis and was treated 1 year prior with a titer of 1 to 64. At that time, she was diagnosed with late latent syphilis and treated 1 year prior with a titer of 1 to 64. She received 3 shots of penicillin G, each 7 days apart. Does this still positive test mean she needs to be treated again, or is she fully treated? For that, we need to understand a little bit about treatment failure. Treatment failure is defined as persistent of clinical signs and symptoms, or a sustained greater than 4-time increase in non-treponemal testing for greater than 2 weeks. And primary and secondary syphilis, it's a failure to see a 4-fold decrease after 12 months, However, it is important to know that 10 to 20% of patients will not achieve this fourfold decrease within the 12 months. For latent syphilis, the failure to see a fourfold decrease after 24 months, and it's more common to not see this if the initial titer is 1 to 8. So let's talk about how we interpret titers. So while you may not see evidence of treatment failure, interpreting syphilis titers are important as they may show evidence of reinfection. Non-treponemal test antibody titers, like the RPR, are used to follow treatment response and look for evidence of reinfection. Quantitative testing involves the serial dilution of serum specimens to determine the amount of non-treponemal antibody present. A fourfold increase in the non-treponemal titer is always abnormal. A fourfold change is equal to 2 dilutions, and it's really what we need to see for a clinically significant difference. So for example, if you go from 1 to 16 to 1 to 32, that's a 1 dilution change or a 2-fold increase or decrease in titers. Compare that as to 1 to 8 or 1 to 32, which is a 2 dilution change or a 4-fold increase or decrease in titers. Non-treponemal test titers usually decline after treatment, as we talked about earlier, and they may become non-reactive, but in many people, the non-treponemal antibody titers will persist, a response referred to as the serofast reaction. So because Jen's titer had gone from 1 to 64 to 1 to 1, it had reduced by more than 4-fold or 2 dilutions, and she was considered adequately treated. Her titers were not consistent with a new infection, and she did not need further treatment. However, Jen returned at 32 weeks. She was asymptomatic, but repeat screening labs were notable for a reactive RPR with a titer of 1 to 16. This represents a more than 4-fold increase and is consistent with a new infection. It also again highlights for us the importance of ongoing testing during pregnancy. Jen was treated with penicillin G 2.4 million units once for early latent syphilis. So now that we hopefully understand syphilis in the pregnant person, I do want to talk about their children. The Red Book is very clear that no newborn infant should be discharged from the hospital without determination of the mother's serologic status for syphilis. So we've already covered identification of syphilis and adequate treatment in the pregnant person. These are the first 2 steps, while the next 2 steps focus on the child and newborn themselves. The pathophysiology of congenital syphilis is kind of fascinating. At the onset of congenital syphilis, spirochetes are freed directly into the circulation of the fetus, and they disseminate widely to almost all organs. The clinical manifestations we see actually result from an inflammatory response to these spirochetes, so they can be varied and widespread because they depend on what organ they're in. The first step is looking for clinical symptoms, and these are just some of the most common manifestations of clinical syphilis. Hepatomegaly occurs in almost all infants with congenital syphilis and can be associated with lab abnormalities like jaundice and cholestasis, as well as elevated liver enzymes. Syphilitic rhinitis or snuffles usually develops during the first week of life. It's more severe and persistent than the nasal discharge of the common cold, and the nasal discharge actually contains spirochetes, is extremely contagious, and can transmit infection by direct contact. The bold ones here contain spirochetes that can be infectious and require contact precautions. An exam looking for congenital syphilis needs to be complete because it can infect almost any organ. This is a really nice image from a recent New England Journal article focused on congenital syphilis, highlighting all the different manifestations that you can potentially see. I also put some of these classic images from the CDC, including rhinitis with mucopurulent nasal discharge or snuffles, the typical desquamating and macular-papular skin lesions, punched out pale blistered lesions, mainly on the ears, nasal bridge, and desquamation of the feet and palms. Hepatosplenomegaly and jaundice in an infant with congenital syphilis, and black markings on the infant indicate the liver margins. And finally, X-ray of bone abnormalities with syphilitic metaphysis in an infant with diminished density right here at the end of the tibia. But you don't necessarily have to have symptoms of congenital syphilis to have congenital syphilis. This slide shows the proportion of individuals with congenital syphilis who are alive without documented signs and symptoms, which is the largest dark green area. There's alive with some signs or symptoms, which is the lighter green area, and infant deaths and stillbirths, which are the blue area or blue lines. In addition to clinical signs and symptoms, you also have to look for lab signs of congenital syphilis. These can be subtle findings like anemia, thrombocytopenia, leukopenia, leukocytosis, or CSF abnormalities like an elevated white blood cell count, elevated protein, or a reactive VDRL. And finally, radiographic findings like periostitis, metaphyseal serration, and destruction of the upper medial tibia, which can all be diagnostic for congenital syphilis. And the final piece of information you need to put this puzzle together are a comparison of maternal and neonatal non-treponemal titers. These need to be from neonatal serum and not cord blood due to the potential contamination from maternal blood in cord blood. And the goal is to compare maternal titers and neonatal titers with a focus on whether the infant titer is fourfold higher than the mother's. And so now that we've reviewed the workup for the babies and what each of them will need after birth, just want to remind you about each of our patients. Jen had a new syphilis infection during pregnancy. She was treated with penicillin at 32 weeks. However, her baby was born prematurely at 34 weeks via C-section due to fetal distress. The baby's exam was normal at birth. Eve was diagnosed with latent syphilis of unknown duration, treated with penicillin weekly for 3 weeks, starting at 12 weeks gestation, and retested at 28 weeks. At that time, her RPR titer was down to 1:1, and her baby was born at 38 weeks via normal spontaneous vaginal delivery, and the exam was normal. Finally, Alex was not treated as she had a positive RPR and negative TPA. She was diagnosed with a false positive RPR, and her baby was born at 40 weeks via C-section for failure to progress with a normal exam at birth. So now we need to pull this all together to review the management of infants less than 4 weeks of age. Based on our evaluations of the pregnant person and their baby, there are 4 potential scenarios. These are clinical scenarios, which I do recognize differ a little bit from DIS scenarios, but 4 clinical scenarios that affect our management. Proven or highly probable, possible, less likely, or unlikely. And these scenarios help us decide what further evaluation, or if any, and treatment is necessary for the baby. I think that proven or highly probable is the easiest criteria. In this case, the mother tested positive during pregnancy. The baby has an abnormal physical exam that is consistent with congenital syphilis. The baby has a serum non-treponemal titer that is 4-fold higher than the mother's titer. Or the baby has direct evidence of direct detection of treponema pallidum, for example, in mucopurulent nasal discharge. Those babies have proven or highly probable congenital syphilis. And because it's proven or highly probable, the workup is extensive. All babies should get a CSF analysis and a CBC, and a variety of other tests as clinically indicated, including long bone radiographs, chest radiograph, liver function test, neuroimaging, opto exam, and auditory brain stem response. In practice, we do frequently do much of this workup for patients with proven or highly probable congenital syphilis. In terms of treatment, the general treatment is intravenous penicillin G, 50,000 units per kilogram IV every 12 hours for the first 7 days of life, and every 8 hours thereafter for a total of 10 days. Because it's proven or probable treatment, the entire course should be with penicillin. And if more than 1 day of therapy is missed, the entire course should be restarted. I do have an alternative therapy here, which is procaine penicillin, but given that it's no longer available, I'm not going to mention it any further during this discussion today. Our second scenario possible is a little bit more complicated. It starts with the pregnant person testing positive during pregnancy. In this case, the baby has a normal physical exam and a reassuring serum quantitative non-treponemal titer that's either less than or equal to 4 times the maternal titer. But there are one of the following concerns. The pregnant person was not treated at all. The pregnant person was inadequately treated, which include using non-penicillin regimens or not treated completely for their stage. For example, only receiving 1 injection for latent syphilis. The pregnant person has no documentation of receiving treatment, or the pregnant person received appropriate treatment, but it occurred less than 4 weeks before delivery. In the possible category, recommended workup includes a CSF analysis, complete blood count, and potentially long bone radiographs. In terms of treatment, the treatment is very similar to before, with IV penicillin for a total course of 10 days. However, in this case, there is a second option of benzazine penicillin G, 50,000 units as a single dose. So obviously, everyone would prefer a single dose rather than 10 days of therapy. So how do you choose between these two? Well, you should choose 10 days of treatment if the workup is abnormal, the workup is uninterpretable, for example, a CSF that's contaminated with blood, or the workup is not performed, as for example, in some cases, you may just elect to do 10 days of therapy and not perform the workup. One other reason is that it's uncertain that the baby will be able to follow up. You may consider 10 days of treatment. I will also add that neonates born to pregnant persons with untreated syphilis are at increased risk, and a complete IV course may be considered, even if the evaluation is normal. So going back to our patient, Jen, the baby was born at 34 weeks gestation for a C-section for fetal distress. After birth did well with APGARs of 7 and 9. The baby was appropriate for gestational age and exam was unremarkable. The baby's RPR titer was 1 to 2. The baby's mother's RPR titer was 1 to 8, down from 1 to 16 3 weeks ago when she was treated. However, given that in this case, the mother was treated less than 4 weeks prior to delivery, even though the treatment was appropriate for her stage of syphilis and titers are coming down, this baby falls into the possible category. In this case, a workup was attempted, but was unsuccessful due to a bloody LP, and the baby was treated with 10 days of IV penicillin therapy. I'll also note that the baby initially got 48 hours of AMP and GENT for a rule-out sepsis, followed by the full 10-day course of IV penicillin. The third scenario is that of a normal physical exam, serum quantitative non-treponemal serologic titer less than 4-fold the maternal titer, and all of the following. The mother was treated during pregnancy and treatment was appropriate for the stage of infection. Treatment was greater than 4 weeks before delivery, and the mother had no evidence of reinfection or relapse. In that case, no evaluation is recommended. And in this case, there are again 2 options. One is a single dose of intramuscular benzazine penicillin. The second approach involves not treating the infant, but rather providing close serologic follow-up every 2 to 3 months for 6 months. This is a more intensive approach, but is an option, especially for mothers who may be hesitant about giving the injection to their child. And this is what happened with Eve, whose baby was born healthy at 38 weeks gestation via normal spontaneous vaginal delivery. The baby's RPR was 1 to 1. And given that mom was adequately treated more than 4 weeks before delivery, we did not perform any further workup and just gave the baby a single dose of intramuscular penicillin G. And finally, our last scenario, unlikely. In this case, the baby has a normal physical exam and serum quantitative non-treponemal serologic titer less than 4-fold the maternal titer. And mom's treatment was adequate prior to pregnancy. So she was never actually infected during pregnancy. And the mother's non-treponemal serologic titer remained low and stable during pregnancy and at delivery. In this case, there's no need for any evaluation, and there's no need for any treatment. However, they do recommend following infants with reactive non-treponemal test to ensure that it returns negative. Neonates with reactive non-treponemal test should receive careful follow-up exams and serologic testing approximately every 3 months until the test becomes non-reactive, which I think addresses the question we were just asked by Teresa. In the case of patients not treated at birth because congenital syphilis was less likely or unlikely, non-treponemal antibody titers should decline by age 3 and be non-reactive by 6 months, suggesting the reactive test was just caused by passive transfer of antibody. At 6 months, if the non-treponemal test is non-reactive, no further evaluation or treatment is needed. And if it's still reactive, the infant may be infected and should be treated with a 10-day course. For neonates treated at birth, the non-treponemal titer should be non-reactive by 12 months. And if it's still reactive, consider a lumbar puncture and a 10-day course of IV penicillin. Neonates with a negative non-treponemal test at birth whose mothers are seroreactive should be retested at 3 months just to rule out the incubation period. And as a reminder, direct treponemal tests are not used to evaluate treatment because the results are qualitative and passive transfer might persist for over a year. Now that covers the most common scenarios of children in their first 30 days of life, but we haven't discussed everything. There is one other scenario that we sometimes, although less commonly, see. Occasionally, you may get a patient over 1 month of age to evaluate for congenital syphilis. These are generally infants and children who are found to have reactive serologic tests for syphilis when they're older than 1 month of age. The first step is separating out congenital syphilis from the potential of later acquired syphilis, which requires a careful review of the records showing that congenital syphilis is possible. One thing we always have to consider in pediatrics and rule out is the possibility of abuse. If congenital syphilis is possible, then an extensive evaluation should be completed, including a CSF analysis, CBC, and other tests as clinically indicated, including, again, X-ray imaging, liver function tests, neuroimaging, optho exam, and auditory brainstem response. Patients should be treated with IV penicillin for 10 days, or if the workup is completely normal, you could consider a benzene penicillin 3 doses over 3 weeks. And the reason to do all this workup and treatment is that untreated infants, regardless of whether they have manifestations in early infancy, may develop late manifestations, which often appear after 2 years of age and can involve the central nervous system, bones, joints, teeth, and eyes. The good news is that late manifestations can be prevented by the treatment of early infection. If you're interested in learning more about congenital syphilis, there is information on it in the National STD curriculum, as well as the on-demand sexual health trainings put together by our PTC. Just a reminder of the New York City STD Prevention Training Center, we also have a clinical consultation warm line that can help with difficult cases of congenital syphilis. And with that, I will stop and take any questions. And thank you very much.
Thank you so much, Dr. Zucker. That was an excellent presentation and really enjoyed hearing more about this topic. We did have several questions that came in during the presentation that our medical director, Dr. Natalie New, answered. Just a reminder, if you do have questions, please enter them in the Q&A tab. We will be sending out a copy of the slides as well as CME and CNE instructions after the webinar. The webinar will be posted sometime next week on our website. I will type that into the chat box as well. So far, Dr. Zucker, we don't have any questions that are new that were not answered during the webinar, but we can give it a moment to see if anything comes in. So there's a question that came in from Danielle, and it says, what is the best way to treat? Danielle, I'm not sure, or Dr. Zucker, I don't know if you need a little bit more information for that question. She says a pregnant woman who was treated.
You know, in another country, got it. So, I think there's a couple things to talk about when you think about treatment. The first is we're trying to treat based on stage, right? So we're trying to, I'm just pulling up our slides here. We're trying to treat here. So, okay, there we go. So no documentation. So, my recommendation is that if a person does not have documentation of prior treatment, especially if they're pregnant, we tend to default to treating for syphilis of unknown duration. It's very challenging. It's very challenging in pregnancy because we would not want to miss an opportunity to treat. And we would favor over-treatment by retreating than we would under-treatment and allowing some of the complications of congenital syphilis to occur. And so if we can't get documentation, we would generally treat for late latent or syphilis of unknown duration with 3 weekly shots of benzene penicillin. With that said, many of the times, if we really work at it, we can find that information in other countries by speaking to clinics and other things. And if you can confirm they're treated in another country, I would take that as acceptable, but I would want to confirm it myself given just the risk of missing it in congenital syphilis. We're trying to ask why we think there's an increase in congenital syphilis cases. And I really do think it's just because we're seeing more and more syphilis. I mean, as we saw from this slide, syphilis on its own has increased 80% since 2018. And the largest amount of that rise is actually coming in female populations, which is why we're seeing a declining male to female ratio. And so as the number of cases in females of childbearing age increase, I think we're just seeing more cases. It's one of the things that's so important that we increase our screening, not just for pregnant persons, but screen all people who are coming in for sexual health services for syphilis. I talk to ERs a lot, and they're very commonly, when patients come in for STI testing, just doing swabs and not drawing blood. But I think it's really important that we look for every opportunity we can to diagnose and treat syphilis when we can. It's really the only way we'll reverse these trends. Because if you look, the biggest problem is just that syphilis on the whole is going up. We have a question about most patients comply, but some moms are resistant. What is the recommendation for the baby? Whew. I mean, that is a tough one. If mom really had syphilis, then I think and then mom is declining treatment for the baby, I think something that has to be discussed with social work to determine whether or not this is something that rises to the level of being referred to Child Protective Services in certain cases, because they're potentially declining either a necessary evaluation or treatment for the baby. Again, every case is a little bit different, and depending on what your level of suspicion is in that case, I think plays into it. And then working through a shared decision-making approach with mom to make the best decision for them and the child. The next question I see is, can you please address transmission from parents, caregivers of children? Can children get syphilis from being touched or held by someone with a syphilitic rash? The answer is yes. I mean, it is contagious on the skin. While it's not as contagious as a chancre, it certainly is contagious on the skin. There are spirochetes, and the rash could be transmitted in that particular way. And yes, if somebody has syphilis in their mouth and a chancre in their mouth, it could be shared through fomites and other items. It looks like we're getting into the nitty-gritty about specific cases here. So the next one is, if a pregnant person has an initial RPR of 1 to 32, treated with 3 doses of bicillin, plus an additional dose given due to MD request based off RPR not decreased after birth. Most recent RPR is still 1 to 16, no new partners. This would indicate no treatment needed to correct. Yeah, so this goes to the question of what constitutes failure, which I know we talked about very briefly, but I'll pull those slides back up again as well, because I think it's really important, because we're often really expecting things to decrease quickly. I can't see what the timeline is, Amber, there, but generally, if we think she had latent syphilis, you need to see a 4-fold decrease within 24 months. So if it hasn't been 24 months, there's no need to retreat.
And Dr. Zucker, you saw that. Great.
Yep. Next is, how would you handle a case of a pregnant patient with prior treated syphilis and a new slight rise in titer, less than 4-fold, and unable to confirm refute with treponemial test due to prior infection? This is a great question, and this is one we get called about all the time. First, I'll open with, there is no wrong answer and no right answer to this question. What you really want to know is, what are the chances this person was re-exposed to syphilis? If they have only had one partner in that time and you can test that partner and that partner is negative, I think it would be reasonable to not say you have to treat due to the twofold increase. It's not a 4-fold increase, so you don't have to treat. At the same time, if their partner were to test positive and never have been treated before, or they were to have new partners that they're unsure of their status, or they really had any epidemiological vulnerability to syphilis, then I would have a very low threshold for retesting. Or retreating. I will also say, in the case of non-pregnant persons, that's someone who I might consider retesting, but you obviously don't have that type of time during pregnancy, and so you just have to make a decision about treating or not treating.
Thanks so much, Dr. Zucker. I don't see any additional questions at the moment. We can give it another minute and see if there are any questions. Dr. Zucker, any last points that you wanted to add before we close this webinar out?
No, just that it was really exciting to see so many people here today, and I hope this was helpful.
Well, great. Thank you so much. We really appreciate your presentation. We will be sending out a copy of the slides and CME instructions after today's webinar, and we thank you all for joining us today. Thank you.